Knee Osteoarthritis by Jensen Houston, a clinician's path to understand, diagnose, and treat it. Clinicians will note the signs and symptoms they see on the patient and then have the patient take a radiograph and/or MRI of the affected knee joint. Risk factors for the clinician to be aware of include sex, genetics, and obesity. Depending on the severity of the patient's knee osteoarthritis, clinicians will set up a treatment plan that first involves prescribing analgesics and exercise for the patient, typically through guided physical therapy regimens. Application of NSAIDs and intra-articular injections will follow from how well the patient manages pain and can or cannot perform his or her daily tasks. If these non-pharmacological and pharmacological treatments are unsuccessful to the patient's satisfaction, then a total knee replacement is next in order, which will, in most cases, allow the person to be able to actively regain full range or motion and relief of pain, especially through post-surgical physical therapy regimens. Osteoarthritis comes from the words osteon arthron and itis, meaning bone joint inflammation. This usually affects the medial side of the knee and is defined as the progression of articular cartilage loss due to extracellular matrix degradation, bone sclerosis of the subchondral bone, osteophyte formation, and other joint problems like synovitis occasionally. Articular cartilage is avascular tissue made of chondrocytes, proteoglycans, type 2 collagen, and water. It is about 2 to 4 millimeters in depth. It is for weight-bearing and cushioning purposes, and is the smooth surface for range of motion activities of the knee joint. To your right is the picture depicting the synovial membrane, which secretes synovial fluid that basically just bathes the cartilage and brings it various nutrients that it needs. Signs and symptoms of knee osteoarthritis include joint pain, mild stiffness, swelling, tenderness. People usually seek help because of the pain, because of the low range of motion, and because of low bendability, which limits daily actions. The clinician then does a detailed physical examination, radiograph, and/or MRI. Knee osteoarthritis risk factors are age and obesity. It is usually the elderly who are most susceptible here, due to natural cartilage thinning, weak muscle stability, and they are more prone to mechanical injury. It is also known that chondrocytes die as one age, which decreases the extracellular matrix to produce articular cartilage. And in terms of obesity, there's a statistic saying that being 10 pounds overweight increases force on the knees 30 to 60 pounds with each step. Some non-pharmacological treatments include weight loss and exercise. One can use walking aids, canes, and/or lose weight in order for there to be less stress and weight on the joints, and this also improves gait. Exercise plus losing weight together offers the best improvements in preventing symptomatic knee osteoarthritis from manifesting. You should also focus on quadricep exercises. Some pharmacological treatments are simple analgesics and topical creams. Acetaminophen is a simple analgesic that alleviates minor pain. It is typically prescribed 1,000 milligrams up to 3 times daily, with a max dose of 4,000 milligrams. It is contraindicated with liver disease and alcohol. There's also capsaicin cream, where applied, makes pain signals unable to reach brain. The next level of pharmacological treatments are NSAIDs. Some examples are aspirin, ibuprofen, and Celebrex. NSAIDs stand for non-steroidal anti-inflammatory drugs. If analgesics are not working, like acetaminophen, clinicians give the patients NSAIDs for pain and inflammation purposes, for the patient's mobility and range of motion in the joints. This works really well for chronic swelling. Over the counter, 200 milligrams each, prescribed 800 milligrams each. If analgesics and NSAIDs are not working for the patient, the clinician can offer for the patient to undergo steroid and hyaluronic acid injections. Steroid injections offer localized pain relief after a couple hours with mobility improvement. The benefits are short-lived though, about 3 to 4 weeks, and it has been known to degrade cartilage. Hyaluronic acid injections, on the other hand, replenish the hyaluronic acid that is normally within your synovial membrane. It's up to 6 months pain relief with one injection, and it has no noteworthy side effects. Finally, if every other treatment is not working, a clinician can have the patient undergo a total knee replacement surgery as a last resort. It has greater than 97% success rate and satisfaction rate. It lasts 20 years or longer in 90% of patients studied. Less than 1/2 inch is removed from bones and replaced as shown in the picture on the slide. Routine daily tasks but not heavy activity is recommended because the parts can still wear out. This concludes my presentation on how a clinician can understand, diagnose, and treat knee osteoarthritis. Thank you.